Pleasure to return, Dr. Tosi. Thanks for the invitation to come back. Let me just see if I can take control here. I click on this and hope that things go smoothly hereafter. So yes, I've been invited back to the rare bone disease teleecho clinic series, and the topic I chose, skeletal fluorosis, in part fulfills the rare bone disease category, but not perfectly, as I'll show you toward the end of this talk. After all, for skeletal fluorosis, there's a very prevalent endemic form, and then the rare bone disease, non-endemic forms that I'll begin this talk by describing for you. So we start with fluorine. Look in the upper right-hand corner of the periodic table, and there it is, one of the halides, the smallest of them. And among all the elements in the periodic table, there are 16 that are necessary for human development and growth. And fluoride happens to be, or fluorine, I should say, happens to be one of them. Uh, in reality, our reality on this planet, there is no elemental fluorine. It's all fluoride ion because this is a remarkably active element. You can capture fluorine as F2 as a gas, and that's shown here in this vial as a green yellow material. But its origin is actually quite fascinating, hardly something that I could tell you about, but apparently the formation of fluorine in the universe is incredibly interesting, but incredibly complex. But it did make it to our planet, and that's the fluorine that I'll be talking about during the next about 40 minutes. So this is what they can look like in a laboratory, F2 gas. So fluorine, it is the most active of all the elements in the periodic table. And it's remarkable that it can combine with any but three of those elements on the periodic table. So it's the most active of all elements. And this brings us complications that are acute but also chronic. And the chronic are dental and skeletal fluorosis, as I'll describe as we go along. This slide that you can find on the internet captures some of this aspect of fluorine. If you read at the bottom, fluorine gas is so reactive, it will ignite anything it touches. And this is true. And again, this is why on our planet, any fluorine element anywhere is present as fluoride, as the anion, because this cannot exist outside of the laboratory without, in a sense, setting any other element on fire. So this is how it's captured in this nice cartoon that tells us it's number 9 on the periodic table, and they have descriptions, cartoons for the other elements and what they might be doing. So before turning to chronic fluoride exposure, I just wanted to emphasize, because there are endocrinologists, I imagine, listening to this talk, that some of the activity of fluorine becomes manifest by what our chemists can do, and that is they can make hydrofluoric acid. And hydrofluoric acid is used in many industrial processes and some household cleaners. But in its anhydrous form, hydrofluoric acid containing fluoride is so reactive that if you spill that on 2.5% of your skin, you may be dead within a couple of hours. So this is one of the manifestations of that, if you will, hyperactivity of fluorine in pathophysiology. And here is the mechanism of it and an illustration of it that was published, if you could see the bottom of the slide, in the New England Journal of Medicine back in 2007. When here a 45-year-old healthy man was involved in demolishing an industrial plant in which glass had been etched. So apparently he spills some concentration of hydrofluoric acid onto his hand and forearm and ends up in the emergency room where uh, the toxicologists might apply first water to wash off the hydrofluoric acid, but then follow with a calcium gel to try to bind some of the fluoride released in the hydrofluoric acid. And hypocalcemia and hypomagnesemia are an important part of the pathophysiology of what happens next. Also, hyperkalemia that can cause arrhythmia and sudden death in this situation. So what happened here for this gentleman was they infused calcium and magnesium intravenously on an emergent basis, and also calcium in the brachial artery. And what happened was that about 24, 48 hours later, this white material appeared on the fellow's skin. And I think what they're showing here is that this is actually calcium fluoride or magnesium fluoride material that is emerging from the skin. The hydrofluoric acid is now binding with the calcium and the magnesium to give you this kind of precipitate. And for the endocrinologist, if you're called to get involved with hydrofluoric acid toxicity, this is not something to delay for a minute. This is Goldfrank's Toxicologic Emergencies, the sixth edition, a few years ago. But this is a big traditional textbook devoted to these emergencies, and 4 full pages outline how you manage exposure to hydrofluoric acid, be it splashed into an eye, onto the skin, swallowed, etc. So here you're seeing the activity of what fluoride can be in hydrofluoric acid, and something of the acute toxicity. But outside of the industrial world, yes, anywhere else, fluoride is designated F minus, the anion, fluoride ion. And on our planet, it's found predominantly in volcanic rock. You can imagine, like for here in Missouri, where most of the stone underneath our feet is um, uh, precipitated calcium and phosphate sedimentary rock. Um, the fluoride is actually found in volcanic rock, be it igneous or metamorphic rock, which is scattered throughout the planet, so that the fluoride chemists realize that the groundwaters, not the surface waters, but the groundwaters around this planet contain some degree of fluoride. It may be relatively low, but it could be very high. And that's a manifestation of how those waters, those groundwaters, are touching volcanic rock and leaching some fluoride into the groundwaters. We'll come back to that. But what about for us? What are the fluoride sources for us? There's about 1/2 milligram taken in food each day for us. For those countries where we have fluoridated water, that gives us about another milligram each day. And 80% of that is absorbed from the GI tract. Fluoride can bind with calcium, so that probably accounts for 20% not being absorbed. But the 80% that is absorbed, about 50% of it will go directly into bone. 50% will be coming out in the urine. And in our bodies, 99% of fluoride is in calcified tissues. So bones remodeling, and yes, 50% goes into bone, 50% comes out in the urine, but it's not a really dramatic uh, accrual of fluoride over time. Some is being remodeled out of the bone, that's coming out in the urine, so that there is a gradual increase in fluoride load in our skeletons over time. Um, and its skeletal half-life has been estimated to be about 7 years. So if it makes it into your bones and gets incorporated, it's going to be about another 7 years before uh, half of that will come out. It's important to know some of the definitions used to describe fluoride concentration. 1 part per million. Well, for water, that's 1 milligram per liter, 1,000 grams there. So that's 1 part per million. And that's about 1 milligram for a quart of water as well. So if you're talking liters of quarts, 1 milligram is 1 part per million. Then, for fluoride, under most dietary conditions, like I said, fluoride balance is positive. So you're healthy. Some is going into bone. Its half-life is 7 years, but it gradually accumulates over time. And as it gets to the skeleton, apparently there's a rapidly and slowly exchangeable pool in bone. So some can go in and but out very quickly, but most will go into a slowly exchangeable pool. And once it's in there, if you look at the upper right-hand corner, this slide shows you how fluoride ion is similar in size and charge to the hydroxyl ion, and therefore for hydroxyapatite can substitute to form fluoroapatite or fluorohydroxyapatite. And that has a crystallinity. The crystal lattice of fluoroapatite is more compact, less soluble than hydroxyapatite, therefore more stable. And it's resistant to bone remodeling. So if you have high levels of fluoroapatite in your skeleton, it's not going to be removed that easily. And that accounts for some of the toxicity at the skeletal level that comes from excessive fluoride load in your bones. So how did we get insight into skeletal fluorosis and toxicity from fluoride in our world? It seems that it started with dental fluorosis. And you go back to 1908 when an academic dentist named McKay and his colleague Black became very fascinated with something that was emerging in Colorado Springs, Colorado, and that they called Colorado brown stain. They went there and they saw that the teeth of people who were living in Colorado Springs had brown deposits that were apparent clinically. But if they went up to Boulder, Colorado, different sort of water source, they didn't see that at all. So this was Colorado brown stain. And then at the bottom, they noted modeling of the teeth, believed associated with the city's water supply, somehow associated with the water. And they published on this back in 1916. And if you're really interested in the history of dental fluorosis and the emergence of complications from too much fluoride in the water, there's a very beautiful 1 hour, 40-minute lecture by an academic dentist. I don't know his name. I think it was a lecture delivered in about 2005. He, working in South Dakota and in Wisconsin, reviewed quite beautifully over the time allotted for his lecture how epidemiologic studies, propelled by McKay especially at the early part of the last century, started to tell us that uh, fluoride in the water, maybe too much, is accounting for the Colorado brown stains, but there was also a potential benefit. And it's beautifully reviewed, names, times, years, etc. So you might want to see that. But by the 1930s, chronic fluoride toxicity was now being recognized, not only in the United States, but in Europe, because there were folks working in the cryolite and rock phosphate industry for fertilizers, and they were developing skeletal disease. And worldwide, a disorder was being recognized from contaminated well water, where it seemed that if now you could measure fluoride if there was more than 3 parts per million, and in a country with a hot climate, skeletal disease was beginning to emerge. And again, this is the 1930s. And then the radiographs were taken, skeletal fluorosis X-rays, and what the characteristics were revealed to be included diffuse osteosclerosis. That refers to coarse trabecular bone. And then part of the skeletal pathology was also painful periosteal reaction of long bone diaphyses. So that's a hyperostosis. And then there were knobby calcifications and tendon insertions. So these three became, um, I think, very characteristic of skeletal fluorosis. And the radiologist would suspect the disease based on these changes in the skeleton. And here's one illustration of it. This is the interosseous membrane, and the arrows are pointing to calcification of that interosseous membrane in an otherwise dense skeleton. And this is almost unique to skeletal fluorosis as a radiographic characteristic. And then what was interesting was, as you're trying to figure out what's causing the Colorado brown spots, the dentists were recognizing that pre and post eruptive exposures to fluoride also seemed to have a potentially beneficial effect, to have a karyostatic effect. If you were going to develop Colorado brown stains or brown spots, you weren't likely to be showing cavities. So, was there something in the epidemiology that suggested a benefit from fluoride? And then this eventually led to dental caries prevention in the United States and then elsewhere, recognizing from the well water and the epidemiology of the groups, the towns that did have brown spots but had cavities versus those that didn't have the spots and didn't have the cavities. It was set at about 1 part per million would be the nice fluoride exposure in your drinking water. So water fluoridation begins in the United States in about the 1940s. The optimal fluoride levels in U.S. city water is set to be about 0.7 to 1.2 parts per million, depending on the ambient air temperature. So that if you're down in Texas and you're in hot weather, they might set the amount at 0.7 parts per million because you're going to be drinking a lot of water. But if you're up in Minnesota and you still want to get the fluoride into you, maybe you're going to be drinking 1.2 parts per million up there. And by the next decade or two, fluoridation of water was achieved for about 75% of the US population. So, how did I get interested in this? Way back in the 80s, we actually, in the era of ADFR for osteoporosis, we used sodium fluoride in children with OI to see if it would be of beneficial effect as a pharmaceutical. Um, but my first encounter with toxicity came in 1998 when a 50-year-old woman was referred to a clinic, and I saw her for dense bones. She had twisted her back, and X-rays showed vertebral osteosclerosis. And when I saw her, she told me that she was having pain and morning stiffness in the neck and her back for the past 5 years. And the docs had told her she has disc disease. She never had any fractures by history. So then I looked at the x-rays from 1998 on the right, and you see there's coarse trabecular bone, but there's also coarse end plate material. And this is something that looks like renal osteodystrophy, but our creatinine and the rest was normal. And it could be Albert-Schoenberg disease, osteopetrosis. But if you looked at the x-ray on the left of hers from 1993, it was normal. So this wasn't something that she was carrying lifelong. So she had an acquired change in her bones. And then we did DEXA. And I like to make this point whenever I'm talking about dense bones, because look at the bottom. She has T scores of +8, +9. She has Z scores of +9, +10. And if you look at the actual picture, you just see that dot. And if you don't know what that dot means, you won't realize, if you're going just to the bottom line that I'll talk about, that she actually has dense bones. So, point here is when it comes to dense bones, you're not really interested in osteoporosis anymore. So T scores are sort of out, and what you want to know is how that individual with dense bones compares to their age and gender matched normals. So you're using Z scores. But there's problems diagnosing dense bones to this very day using DEXA. And I think it's a result of the World Health Organization criteria for diagnosing of bone status. And understandably, this was created to deal with osteoporosis. And they developed the T score you're familiar with, referable to healthy young people. And at the very bottom, -2.5 or lower in fracture, well, you've got severe osteoporosis. But then look at the top, -1 or higher. The classification was considered normal, no increased risk of fracture. That's how a z-score of +9 to this very day, 20 years later, would be the bottom line in a DEXA report. +9 z-score, but oh, that's higher than -1. So normal and no increased risk of fracture. So I tried to straighten that out, misinterpretation of osteodensitometry with high bone density, thinking that, well, what are you going to call too high? A BMD z-score of +2.5, I thought should somehow be, at least in the clinician's mind, is not normal. There was a subsequent study out of Cincinnati that suggested, well, maybe in the spine up to 4 could be okay, but elsewhere in the normal range. So we don't know the exact tolerance for what we call too high, but it's maybe +2 or higher. Maybe some individuals might be +4, but elsewhere they'll have normal density and you don't worry about them. But then, okay, she's got dense bones. Then you look at this disorders that cause elevated bone mass, and you have these. You've got the skeletal dysplasias. In the past, very much the territory of the dysmorphologists and the radiologists. Then you had the metabolic dense bone diseases. Fluorosis is there, but then there's also heavy metal poisoning, hypophosphatemic osteomalacia, milk alkali syndrome, renal osteodystrophy, and a group of others that might include mastocytosis, indolent myelomas, myelofibrosis. So what's going on with this lady? I do point out to you, though, that all of these disorders now are understood at the gene level. So rheumatologists and endocrinologists, they are heading to you because, doc, If you know the gene that's defective, you know something about the protein that's defective, have you got a treatment for me? So these folks are heading towards you all, and cumulatively, they're not rare. So back to this patient. So causes of increasing high bone mass in adults. You start looking through and okay, there's the dysplasias. We know the genetic defect. Maybe we could figure them out by their X-ray characteristics. But then there's the metabolic. We see them there. And then there's others. We see them there. But skeletal fluorosis is the first of the metabolic. So what did I have to do? I had to consider all of these as possibilities and exclude them for this patient. So, okay, skeletal fluorosis. And this is back in May of 1998. I thought, well, she's Missouri. We haven't got volcanic rock really here. There's no history of skeletal fluorosis for Missouri. She has a well, so okay, I'll collect a 24-hour urine and look at the elevation of her urine fluoride level. A month later, I said, I need to repeat this to see if it's true. And yes, it's high once again. And then because she had well water in a town that she told me does check the fluoride level and it was okay, no worries, I thought put a filter on your tap and let's see what happens to see if the fluoride level elevation goes away. And no, it didn't. She remains high even now she's filtering her well water. So here are some definitions. The Public Health Service in the United States talks about zero point 0.7 to 1.2 parts per million drinking water as what's okay. 1989, we're up to 9,400 public water systems that are fluoridated. 135 million Americans are getting it, with 6 outbreaks of fluoride poisoning related to that. Things can go off the tracks. Here's a New England Journal of Medicine article about acute fluoride poisoning from a public water system up in Alaska, where they didn't monitor, they didn't get the dosing right, and nearly 300 people developed nausea and vomiting and diarrhea. One of them died, and the concentration of fluoride in their drinking water was 2,800 parts per million, not 1 part per million. So have to be careful. The U.S. Environmental Protection Agency joins and talks about national primary drinking water regulations and comes up with this interesting thing that maybe is still current. I'm really going back a number of years to come up with these slides, but there's a no observed adverse effect limit, a NOEL for fluoride, which talks about preclinical skeletal fluorosis occurring if you're drinking or getting in 10 milligrams of fluoride a day for 10 years. Well, maybe your bone density is going up, but you're not feeling ill effects from it. Whereas the lowest effect level then is if it's 20 milligrams a day for 20 years, you might very well be becoming symptomatic. And therefore, they set a maximum primary contaminant level of 4 parts per million. They don't want you drinking water or things, drinking water with more than 4 parts per million fluoride. And then the USPA says, okay, it becomes multi sort of organizational definitions here. US EPA 4 parts per million tap water. World Health Organization, okay, there are hot countries out there. Not everybody's got cooling mechanisms, and they say 1 part per million in well water. The Public Health Service, in charge of water fluoridation, sets it at zero point 0.7 to 1.2. And the FDA is now regulating bottled beverages and saying 1.4 to 2.4 parts per million is the range that this should be in. So, what happens next here? Sources of fluoride toxicity. What's going on with this woman? And you look, she wasn't taking fluoride for osteoporosis. She wasn't pediatric. She wasn't chewing betel nut and leaves, as I think folks in India enjoyed doing. She didn't chew tobacco or snuff. Brick tea, didn't know what that was. Infant formula, certain wines, no. Teflon pots, no. Pesticides, hydrofluoric acid, no. She didn't work in industry. She wasn't welding. She didn't use those laundry powders. She didn't take nonsteroidals. She didn't get vapors in laboratories. She didn't drink certain sparkling mineral waters, and she wasn't a toothpaste swallower or somebody who swallowed mouthwashes. So I'm looking at this and I see brick tea. What's brick tea? So I look at brick tea, and this is an inferior quality tea that was consumed at that time in very great by numbers of people in China, Tibet, and Mongolia. And it's a compressed mature leaves, twigs, and berries, I suppose in the shape of a brick when you buy it, coming from Camellia sinensis, which is the plant that gives you black and green tea. For some reason, that plant accumulates fluoride in its leaves, its berries, and some of its twigs. So I go back, and why didn't her urine fluoride decrease with new filtered well water? Then I am fortified with brick tea in that sense, and I say, by any chance do you drink any tea? And she says, "Oh, yes, for my entire adult life, I drink 1 to 2 gallons of Lipton instant tea, double strength. Yes, in 1991, it became decaffeinated. That turns out to increase the amount of fluoride absorption. And okay, if you're drinking 4 to 8 quarts of unfiltered well water in your house with 2.8 parts per million, you're getting 11 to 22 milligrams of fluoride per day from your tap water alone. So you're flirting with the Noel, you're flirting with symptomatic skeletal fluorosis. But I then said, okay, stop the tea because we knew about brick tea and how the plant accumulates it. And then look, her urine fluoride levels now drop into the normal range by stopping instant tea. And we look by sending off tea samples made in distilled water to 2 certified laboratories in St. Louis. And we're studying Lipton instant tea, Nest tea, instant tea, those sort of things. And if you look at the mean values on the right, those are the levels in milligrams per liter that we saw. So we concluded that she had skeletal fluorosis from drinking an inordinate amount of instant tea. But if you go to the USDA, they actually talk about how maybe 3% of North Americans drink 1 or 2 gallons of fluids each day. So we're thinking, oh boy, we bumped into something that's a rare skeletal disease, but I don't think we're going to see it again. So tea, I don't want to spend too much time here. World's most popular beverage still appears in London in 1658 as tea. 2 years later, it's thought to have good properties. After all, tea would cure almost any known ailment, maketh the body active and lusty. So in the US, although we're considered a coffee drinking nation, about 10 years ago, I suppose this is the 1980s, there was a burst of enthusiasm for tea drinking in the United States, so that more than 125 million Americans were drinking tea daily in one form or another. And it could be hot black tea, iced tea, ready to drink tea, etc. So then we bump into another case. Skeletal fluorosis from instant tea. This time, instant tea, large volume, extra strength, and this one is Nest tea. Then a few years later, we get involved with skeletal fluorosis from brew tea, not instant tea, but so-called sun tea, where you take the tea bags and you put them into the sun, into the water, and 24 hours later you have a beverage. So here is one rare cause of dense bone disease, skeletal fluorosis. It turns out that Dan Rao and his colleagues got involved out of Detroit with a New England Journal of Medicine letter. Skeletal fluorosis due to excessive tea drinking, where this one sort of is the extreme. Here's a woman who into a jug puts 100 to 150 tea bags, and that liquid she drinks every day, and they report her skeletal fluorosis. So, what are the other new causes of non-endemic skeletal fluorosis? Huffing. You remember that Freon was used for a while, but then started to destroy the ozone layer. That was a fluorocarbon. But along came difluoroethane, which is the propellant in computer cleaners. And some folks will spray it onto a hanky, some will push it into a paper bag, and by inhaling the difluoroethane, they have a high from it. But this causes something called periostitis deformans, shown here. Now the radiologists become aware of it as this extraordinary periosteal bone formation as characteristic of this type of skeletal fluorosis. So you've got the periostitis deformans, and you've got some sort of exostoses together with the dense bones as radiographic characteristics of skeletal fluorosis. The radiologists talk about these multiple painless masses. It goes into skeletal radiology, and now they're helpful for those who are still reading conventional radiographs to recognize skeletal fluorosis. So yes, we start encountering this. Then here's the hand of a young fellow, followed by Joe Tucci in Providence, Rhode Island. That's what his leg looks like from this periostitis deformans. He breaks his femur and eventually realizes that he has to stop huffing for his skeleton heal, and does that. Otherwise, before he stops, this is what his bones look like. And look at the huge periostitis deformans for him. So he gets published. Then Fiona Cook in North Carolina encounters another case and points out how secondary hyperparathyroidism is common here with a literature review. And quite beautifully, she outlines the non-endemic cases of skeletal fluorosis and the likely source of the fluoride in the United States. And this table is very valuable for showing how else you can get skeletal fluorosis here. The most remarkable case in some regard was sent to us by Alan Burchell out of Louisiana, New Orleans. And we entitled this paper Periarticular Calcifications containing giant pseudocrystals of something called francolite in somebody who was 1,1-difluoroethane huffing. And this was an interesting story. This woman had low alk phos, bone disease, this ectopic calcification, and wondered about, could she have hypophosphatasia? But there were characteristics about the skeletal radiographs to Bill McAllister, the radiologist here, his superb eye that said, no, this isn't hypophosphatasia. This looks like fluorosis. And then high levels of fluoride were found in her urine. Her mother contacted me by telephone and said, isn't this hypophosphatasia? And I said, no, it looks like the x-rays look like skeletal fluorosis, and the urine had a lot of fluoride in it. And I very gently went through the conversation saying, did your daughter have any history of toothpaste swallowing? No. Does she drink a lot of tea? No. By any chance, did she inhale any of these propellants that you find in cleaners? Yes, she did that years ago, but stopped. But then obviously it had returned. And those periarticular calcifications were part of her skeletal fluorosis. And unlike in hypophosphatasia, I suppose these are her real teeth, but you don't see any Colorado brown spots on them. What you do see is that she's got maxillary bone exostoses. So by inhaling this fluorocarbon, it's going right into the bone directly where she's huffing, and exostoses are forming. The calcification around her toes was removed, and eventually we sent it to Alan Boyd at Queen Mary's Hospital in London for superb electron microscopy and spectroscopy. And to make a long story short, she had pseudocrystals around her toe of francolite, which is fluorohydroxyapatite that's highly carbonated. And then went into rehab, and we hope she's doing okay, ceasing the huffing. Can you recover from skeletal fluorosis? This was, we put it as an enigmatic American case. Etta Curlin at Columbia, New York, sees a man who gets into a car crash because he couldn't turn his neck. It was too painful. And to make a long story short, he's diagnosed with having skeletal fluorosis, but isn't telling us where the source might be. His bones look like that. And if you look here, um, alkaline phosphatase, 2 years, 7 years, pre-diagnosis, it's gone up. And then look at the right of panel A, diagnosis. Suddenly the alkaline phosphatase goes down. Urine NTX is elevated when he first comes in. He's told his diagnosis, and it goes down. Osteocalcin at diagnosis, elevated, then goes down. And his urine fluoride level goes down. And we don't know where the source of fluoride was, but we reported that he may have, for his clientele, many a day, maybe brushed his teeth between sessions and swallowed the toothpaste or maybe mouthwash. But within months, he felt better. And with the diagnosis, still with the mysterious source, the fluoride sort of corrected itself. What didn't correct itself, though, was bone density. Look here, baseline and then out to 8 or 10 years with biopsies at baseline and then out at 8 years. The skeletal density didn't change much. It didn't recover in his lumbar spine after an initial nice drop, but then it persisted there and in his femoral neck and in his radius over time, uh, consistent with the 7 year half-life. And we predicted from the biopsies with Joe Zerwith measuring the fluoride content that he'd have to live to about 100 before fluoride was normalized in the skeleton. David Dempster looked at his bone on the left. It's um, Goldner stain, and then polarized light microscopy and double labels that David saw after 8 years, the bone was recovering, but still it would have taken many more years for the fluoride to come back to normal. Tim Cundy saw that, and he reported this interesting patient, a lady who'd been taking 40 milligrams of sodium fluoride for many years for osteoporosis. She had had a hysterectomy, I suppose an oophorectomy, and was on estrogen. And she had dense bones. And only when he stopped the estrogen did the bone density start to drop. So by provoking skeletal remodeling, by taking away the estrogen, then the load started to diminish. And with Neil Binkley and Julia Sharif now, there's a patient up north that after she stopped fluoride exposure, received some abaloparatide to sort of stimulate bone remodeling And in Press Now and Osteoporosis International, you could read about what her response to a several-month course of abaloparatide was to relieve her high bone density. Antifungals contain fluoride. I read recently that I think it's something like 20% of all pharmaceuticals have some fluoride in them. The one that stands out is voriconazole, which was used short term for fungal infection, but now chronically. And at the bottom of the slide, 65 milligrams of fluoride each day with a standard dose. And then there are these other medicines with fluoride in them. Prozac, fluoxetine, has a fair amount of fluoride in it. So we have to keep those in mind, as is certain anesthesias. So then effective long-term exposure to fluoride in drinking water, risk on bone fractures. This brought us back to osteoporosis. And now I'm going from rare to extremely common. This was an interesting story, I guess, led by Conrad Johnston out of Indianapolis, where well water was looked at in China. And there was some with it being relatively low on the left, some quite high on the right. And they're sampling the well water and finding these fluoride levels, and then talking to the folks about how many fractures you've had. And you look here, and 5.11 was in the group, the fewest fractures with those with a fluoride content of about 1 part per million. So this publication was provocative in the sense that if you get the fluoride levels into that range, you might be preventing fractures. But of course, in 1964, the first study was done, the 70s and 80s, with much higher doses of fluoride. Cautious optimism by 1989. And then big doses of fluoride showing no decrease in spine fractures, increasing fractures elsewhere, including the hip. And then fluoride fell away from thinking of it as a pharmacologic for osteoporosis. But here now I bring you to this, and it's the last few minutes of this talk. We're talking about a non-endemic skeletal fluorosis as rare. But what's going on around the rest of the world with global climate change? This is a slide I made from a number of years ago, where it talks about how on our planet around 200 million people from 25 nations, 23 developing, are affected by excess fluoride. And those nations included China, India, Pakistan, Sri Lanka, Guyana, Germany, Senegal, Turkey, Algeria, Kenya, I'll show you that, Uganda, Tanzania, Japan, Ethiopia, South Africa, Mexico, New Zealand, Thailand, and Argentina. So these are places where there is volcanic rock, and in certain areas, fluoride's been leached into the water. Um, and this, I asked when I reviewed the paper, please publish this. This is a village in India with these kids said to have skeletal fluorosis, high amounts of fluoride in the water. So this is in certain less privileged countries hardly a rare bone disease for the Alliance. This is endemic and a serious skeletal problem. And with the last few slides, this became sort of apparent in North America when I learned about a man, a Somali, who had gone into Kenya in the Rift Valley where there's volcanic rocks, into the Kakuma refugee camp, 250,000 people there, and 50,000 were drinking water from borehole number 5. And that's what he did for a number of years. He goes to Canada and he arrives and he goes to a new immigrant medical facility complaining of an achy skeleton. And they find dense bones. They do a bone biopsy. They find osteomalacia, but they don't, for a number of years, think about skeletal fluorosis at first. He's drinking Canadian water, and over the next year or two, he feels much better. So what was his bone disease? Drinking out of borehole number 5. That original biopsy was sent to Gary Whitford, and he measured the fluoride content, and the biopsy that was done soon after he arrived in Canada was loaded with fluoride. So the folks in Kenya were alerted to this. They found high levels of fluoride in borehole number 5. They fixed it, and the amount of fluoride was then fixed. But for those of us in countries that see immigrants, if they're coming to you now with achy, dense bones, ask them where they're coming from. Are they coming from any of these countries where volcanic rock has been leached for its fluoride content? And there are reviews. There's attention to this. This is mitigation of fluoride fluorosis coming out of India. They're aware of how it's estimated 100 million Indians have skeletal fluorosis, and they're trying to fix the problem in this way. But here we, understandably, I think, talk about osteoporosis, we talk about renal osteodystrophy, we talk about diabetic bone disease, but I'm not aware of any multinational meeting that's convened to address mitigation of skeletal fluorosis that's nearly worldwide. So with that, I'll close, and I've taken you through a rare forms of skeletal fluorosis, but also told you that it's a very common disorder.
Wow, that was a startling ending. Thank you so very, very much, Dr. Whyte. We're going to take just a quick breather since a number of people joined us late, and to go over our introductory slides, and then we'll come back for some discussion. That was just wonderful. Thank you so very much.
Pleasure.
All right. Can we go back to the intro slides? And great, Melissa. I'm getting there. Melissa, I'm only seeing Dr. Whyte's name. I'm not winning here.
Okay. Sorry, Dr. Tosi, give me one moment. Just trying to get back to the slides.
Yeah.
Sorry, I'm trying to start it over since there were so many slides instead of just going back.
I see. I'm sorry. To push.
Okay. All right.
Great. Okay, here's our introductory slide. I think you now know we are busily discussing fluorosis today. And just to remind you to please, if you haven't signed in yet, please do sign in. It certainly saves poor Melissa a ton of time if you do. And certainly be sure to capture your CME by filling out the red cap. It's 2 different documents. Then please be sure to join us next month. That will be the very end of year 5. And Kelly Roscoe is going to be talking to us about calcium sensing receptor disorders. And that should be a very interesting learning experience. Next slide. And I have begged you, and so far only one person has responded. I hope you'll please give us your thoughts on what you want going forward into year 6. I still have some open slots and want to know what you want. And please go to the chat because the link to that survey should be right there. And then remember that our dedicated OI teleecho sessions are now in full swing. And next week, Mercedes Rodriguez-Salen will be talking about pain, which is a huge issue for so many of our OI patients. And then in August, I'm going to be talking about the nuts and bolts of transition, always a difficult topic. Next slide. And tonight, I urge you to go run around the block, get your circulation going, because our twice a year town hall will be occurring from 6 to 8. Our goal is to be sure that all of our clinics, of which there are close to 60 in the United States, are up to date on the latest and greatest. Kathy Raggio will be talking to us about lifespan issues. Jean Franzone's going to talk about the now really excellent programs for surgeons sharing cases. And then Leanne Ward is going to talk to us about updates in bisphosphonate management, as well as other talks like the impact survey and new opportunities for patients to get together for support groups. So I hope that if you're caring for OI patients, you and your clinic colleagues will join us in just a little bit. And now let's go back to the good Dr. Whyte. Righty, let me see how we're doing in the chat. Okay, so, oops. All right. And, all right, so far, I see lots of instructions for us, but not any questions. I have a really ignorant question I would start with then, which is, you talk about doing biopsies and getting fluoride, but I'm not sure how I would know in a clinical setting where to start. If I saw a patient where I might think there was skeletal fluorosis. Dr. Whyte, can I back you up a little bit? And so I see the dense bone, I get the DEXA, but I'm not clear, maybe I missed it, but I'm just not clear what else to do.
Right. I think if you suspected fluoride toxicity, the commercial laboratories will measure fluoride in blood and in urine. OSHA had a ruling, I think, I don't know if it's still in effect, where arc welders, the folks who are doing welding with a carbon fluoride arc, are at risk of breathing in the vapors as they're doing welding. And they set up a need for an end of shift spot urine to be measured for fluoride and you hope creatinine. And that's the way the commercial laboratories, I think, still see it as the likely specimen that's coming their way. End of shift spot urine for fluoride. But it's very easy to tell them no or to send them a urine collection 24 hours and say, okay, measure the fluoride content and also measure the creatinine content so that you'll get fluoride to creatinine ratio is most meaningful. So that's one way of approaching it commercially. They'll also measure it in the blood. And it's maybe Mayo Clinic Laboratories, Covance, ARUP will measure blood fluoride levels. It's done by a ion electrode. So it's, I think, a fairly straightforward and accurate test. So that's what's commercially available. It's fascinating with working with Gary Whitford that yes, you could ash bone. You can find that that bone specimen was in a laboratory. And let's see, I suppose certainly not decalcified, but if it's one of our metabolic bone disease methyl methacrylate embedded, tetracycline labeled, you can take a few cuts of that. And we sent it to Gary Whitford and Joe Zerwith, and they were able to ash it and measure the fluoride content. And that's how, for Etta Curlin's case, we were able to see very high levels at baseline, and 8 or 10 years later, how only half of it had cleared from the subsequent bone biopsy. But that's a research undertaking. That's nothing that you can order. And then just to round it out, Gary Whitford also realized that although your fingernails and toenails are keratin, you can get a little bit of insight into what was going on 3 or 4 months ago in a patient that may have stopped fluoride exposure if you clipped the fingernails and toenails, and some of our nurses were kind enough to do that as controls without painted nails to contaminate anything. And we sent some of these patient fingernails off to Gary Whitford and the control nurse, finger and toenail specimens. And for about 3 or 4 or 5 months after fluoride exposure ceases, you've got the fingernails that are sort of tattletale, telling what was going on 3 or 4 months ago. So that's published in these case reports. I had limited time, but each of those reports that we published has a great deal of detail in it. So you can get that kind of information by having a look at them.
Terrific. Do we have anyone on the line that would like to ask a question? Then I'd like to go back to your last slides. I mean, what does a country do when 100 million people have fluorosis, which has got to impact all kinds of elements of productivity? If you don't feel well, you don't learn well, you don't work well, etc. You spoke to your mitigation paper, but can you give us a brief overview
Well,
of how they're handling that?
Yes, I mean they've recognized the problem. I think that paper is probably, I think it was 2015. I could send it to you if you want to see it. But yes, they recognize that it is a problem, a big problem, endemic fluorosis. They realize that the culprit is the well water. So what can they do? And this broadens out. They talk about maybe supplying good surface water, let's say from rivers or streams, piping it long distances to these places where the well water, the groundwater, is contaminated. They talk about mechanisms, at least hypothetical, of purifying well water, and there are some ways of doing that. They talk about making the public aware that this is a problem, and if it presents, going for diagnosis. So they're outlining steps. But while that's occurring, and I didn't have a chance to really talk about it, not enough time, here we are with global warming, with temperatures of 127 in the Indian subcontinent. Streams and rivers have become contaminated with pesticides, and they've contained too much fertilizer. So with streams and rivers drying up, contaminated as they were, I worry, and I don't really have my finger on the pulse here, but what is going to be the solution? It's going to be maybe to drill wells and pump up groundwater to provide drinking water for people. And if it's not being assayed for its fluoride content, and in Pakistan, not only fluoride, but I think arsenic, there's going to be a lot of groundwater produced disease coming our way with the heating of the planet and the drying up of good water sources.
Yikes. I am absolutely sure I don't have a good idea on that one, but I certainly can see the need, since desalinization is so very, very expensive. It just won't be open to those countries at all. Interesting. Thank you. I'm interested that the pain complaints improve so quickly. I mean,
Actually,
I
it's
realize you were saying a year, but given how the bone was so involved, why do you think the pain complaints improved so relatively quickly?
Well, let's see. First of all, when I was talking about the man who crashed his car with the neck pain, that was remarkable because despite his very substantial skeletal fluorosis, um, his neck pain and stiffness went away, I think, after a couple of months. That was interesting. But for the other folks, the tea drinkers and some of the huffers, the pain would go away over about a year or two. And that may be, there's actually bone biopsy information. I'm trying to think, at the Curlin's patient, David Dempster looked at the bone at baseline and then the iliac crest biopsy 8 or 10 years later. And I didn't show that histopathology, but there was a terrible osteomalacia by Goldner stain, lots of osteoid, a very thick trabeculae. The bone by polarized light microscopy was lamellar, but there were no double labels. So there was overt osteomalacia, but at baseline. But then in the bone biopsy, that was 8 or 10 years later, the bone was actually remodeling. There were double labels. So the osteoblasts were working, the osteoclasts were attacking. Bone remodeling is being restored. But if you followed symptomatology, you might say, well, maybe bone remodeling is being restored. Now you're healing the micro cracks that were present in the skeleton from the hardened fluorohydroxyapatite crystals. Maybe it takes a year or two for the micro cracks to heal. I don't know if there's any sort of atypical fracturing going on from the osteomalacia pseudofracture. So it might be an explanation and restoration of bone remodeling that accounts for a 1 or 2 or 3 year time period for things to get better.
Interesting. Thank you for that follow-up. All righty, those are my questions. If there's anybody on the call that has a question, I think that we're a small enough group. Please feel free to speak up. Do I hear anybody out there?
I just want to thank Dr. Whyte for his teaching on this. I feel like I've been seeing this in clinic more and more recently, and his publications and consultations have been incredibly helpful.
Can you tell me why you've been seeing them? Where do you, I'm sorry, I don't know you. Where are you practicing?
Sorry, Christine Swanson, University of Colorado, endocrinology, I believe. Well, and they get presented in our local bone conferences. So I think some have been due to huffing. I think that's, and then a couple due to well water.
Thank you. I mean, then for those of us who take care of teenagers, that is not a joke. And are they like huffing extra, or is this something where we may be facing some sort of epidemic?
These
in
were
the future?
adults. I think that they were huffing computer cleaner, you know, the things that people use to clean the keyboards. So they were huffing that.
What you
And
might
it
like
gives
to
them,
do, what you might like to do is next time you are asked to give a conference, and it's going to be around skeletal fluorosis or dental fluorosis, go on the web and just type in skeletal fluorosis and look down a couple of rows, and you'll see a black and white picture and a 1 hour, 40-minute time frame. With this, like I mentioned at the beginning, this clearly academic dentist, I think talking in about 2005 to a meeting of dentists, but he goes through the history of Colorado brown spots being detected in Colorado Springs, but not in Boulder, Colorado, and goes through the whole history of the epidemiology of dental fluorosis and then prevention of cavities and maybe on to skeletal fluorosis. So it is a master class in the history of this that begins in your state that the folks in Colorado might like to see.
Yeah, that was interesting to hear you talk about. I wasn't aware of that history, so yeah, I will listen to that when the next time I give a talk on this.
Yeah, what you might want to do is edit out some parts if there's going off on a bit of a tangent, but the history of it and the importance of Colorado and the dentists and the epidemiologists there is absolutely superbly outlined in that beautiful, accessible bit on the internet.
Yeah, agreed. And I just remembered while you were speaking, another case or two were due to tea, excess tea.
Oh, really?
Yeah.
Your retirement community. Christine, just help me. Is this because I am totally unaware of any of this. Is this an inexpensive high, a particularly nuanced high? How did they even find it as a high? I guess that's probably out there on the internet and I just didn't notice.
Yeah, I don't know the answer to that, unfortunately. This usually comes to our attention because it's usually the pain, bone pain, or they are found to have the secondary hyperparathyroidism. A bone density is done for some reason, and they have the high bone density, and then the evaluation proceeds, and they have high fluoride levels and no evidence of the other causes. And then, we ask about sources, and then that's where it, comes together.
And that history, I think if it was two papers that I would suggest you read, it's Fiona Cook, the one about secondary hyperparathyroidism being prevalent, especially in huffers, because she reviews some of the cases, some of the prevalence of this huffing abuse in that publication. And this is not a small group of individuals who do this. It's much bigger than you might think. And apparently, young folks have been found dead along their computer pods because during lunch or something, they would huff the computer cleaners. And it's not uncommon to hear about people going and buying 15 cans of this and huffing 15 cans of computer duster a day by putting it into a handkerchief or spraying it into a bag and then huffing it in that way. It's an enormous exposure to fluoride. And I don't know if anybody's ever looked to see what the fluoride level in the bloodstream is right after an episode of huffing. So it's a potentially lethal habit.
And is there anything unique about the bone pain? I mean, I get teenagers, with a vitamin D less than 4 who come in with bone pain and it's sort of diffuse body aches. Is there anything unique about this pain?
I would think that the periostitis deformans gives you foci of pain that isn't the generalized achiness, let's say, of an osteomalacia.
Yeah.
You've got these spots. The fracturing could be there. And then the other case about huffing is Nilton Salas Rosanetto's paper that we did with Alan Boyd at Queen Mary's University in London with that beautiful imaging of the francolite, because Nilton does a beautiful summary of the habit of huffing, its prevalence, what it's called in medical communities, etc. So those two papers will guide you to the importance of huffing and the pathogenesis of the complications.
And Dr. Whyte, I may have missed this in your papers or in your talk today, but why is it that it classically is thought to spare the forearm? You know, BMD is high at the lumbar spine and the hips, but the forearm, if you check it, isn't quite as high.
I don't know,
Especially
maybe,
the secondary hyperpara.
yeah, maybe it's the secondary hyperpara. But if the forearm is okay, look at the fingers
Mm.
of that hand with the periostitis deformans. So maybe it's the hyperpara part of it. And then you're also looking, I suppose, are you not with 1/3 distal radius or something? You're looking at cortical bone,
Yeah.
not the trabecular bone like you're seeing in the spine and the hip, let's say. So maybe that's an explanation for the
Lower turnover.
yeah, unless you've got a lump of periostitis deformans there. But then again, what's the DEXA going to say? Oh, you've got a big wide bone there, not so much mineral in there. Even though it's very painful and it's expanding your forearm.
Well, thank you very much. I really would not have thought about the huffing as intensely. And as kids are getting into more and more challenging behaviors, thank you for the awareness. That's for sure. All righty. So, Dr. Whyte, this was, as always, far more thought-provoking than I thought it would be even. Just a great afternoon. And we thank you, and I thank you on behalf of everyone who attended. And we look forward to seeing everybody next month. That's for sure. And please send me your ideas. Have a great day, everybody.